Good morning. Has everybody had their coffee? I've had about 4 cups since I got in about 1:30 last night. So if I'm speaking too fast, just raise your hand, tell me to slow down. But really excited to be here, give you kind of the tip-off of where we're going, the whistle-stop tour of radiation oncology. I have an identical twin brother who's also a radiation oncologist. My father was a radiation oncologist and was the chairman at Wake Forest. And when he was doing radiation oncology back then, we didn't even know what P53 was, much less epidermal growth factor receptor signaling. Patients were treated in a variety of very unsophisticated approaches. Patients were set up in radiation oncology based on bony landmarks alone. God knows whether we were hitting the tumor or not at the same time. And so things have, obviously dramatically changed a lot. Now, these are notices and disclosures. Radiation Oncology 101. So this is typically what most people used to think of as radiation oncologists. Certainly my medical oncology colleagues, thought of us as being down in the basement. There's no windows. We only come out at nighttime, flip a switch, get treated, shut the machine off, go home at night and do it. But I actually tend to think of us more like this, and a little bit more sophisticated in terms of what we do. So when you talk about targeted therapies, when you talk about different types of drugs that target agents, when you talk about chemotherapy that targets cancer cells, we have really become an extremely sophisticated way of delivering a targeted type drug, which is photons or proton radiation. And it's become almost Star Wars-like in some of the things that we're able to do, which is absolutely critical to be able to get to that next level, to the next step. In the old days, again, when we treated head and neck cancer, we treated typically with fields just coming in from the right and the left side, and then a matching field down the lower neck to try to capture all the lymph nodes as well. The good news about this approach is you don't really, when you treat almost the entire head, you don't miss a lot of cancer that way. The problem is you're treating almost the entire head, so you're not missing all the critical normal structures, and patients have a lot of toxicity. I still remember my dad telling patients as they dried their mouths out back then, 2 weeks into treatment, listen, if you may have a dry mouth the rest of your life, but you'll still be alive. Well, that's not acceptable anymore. The point is to be able to deliver incredibly sophisticated radiation, but at the same time sparing the normal tissue so you still feel like a normal human being. Really, radiation is designed to kill cancer cells at the right dose. And if you give enough radiation, you're going to kill the cancer. Problem is, if you give enough radiation or too much radiation, you're going to kill the person as well. And that can be a problem. And so the normal tissues surrounding things are the limitations, especially in the head and neck area. It's one thing to treat prostate when you're just kind of worried about the bladder and you're worried about the rectum. Well, when you're treating the head and neck, there's so many critical structures that you have to try to avoid that it can be a real problem if you're not careful. And as a mentor of mine once said, radiation is the gift that keeps on giving. And you see toxicities that really hit patients 5 years and 10 years out, and they're not trivial. So what are some of the advancements in radiation therapy over the decades? We began to look in the 90s at 3D conformal radiation where we could visualize things and use CT planning. We began to start to look at stereotactic targeting in the 2000s. We began to look at IMRT. What does IMRT stand for? Intensity modulated radiation therapy, where we began to have the ability, the software and the hardware to begin to start to change the fluence or the energy of the beam as it exited the linear accelerator, and as it rotated around a patient dynamically, we could then start to soften it and make the beams curve around critical structures like the spinal cord, like your parotid glands, like your submandibular glands. So things that we weren't really capable of doing before, and not just in one plane, but non-coplanar beams coming in at any angle that we wanted to, based on the fact that not only could the machine rotate around a patient, but the table itself could actually dynamically rotate while the patient was on there. So that was really exciting, and it allowed us to start doing some things that we really didn't think were possible 15, 20 years ago. Stereotactic radiation, for instance. Normally when we treat a lung cancer, might be 6 weeks, 7 weeks of radiation. That's the same in prostate, head and neck. Well, we started asking the question, if we have the ability to target these things so precisely, why are we treating patients for 7 weeks? Can we treat them in 1 week? And can we do it safely? And can we improve the local control in those types of patients? And in lung cancer, it's one of the first areas where we could begin to target a lesion here and treat it extremely sophisticatedly, very fast, in a way where we are actually dose painting our radiation. So you become an artist with the radiation, and you can paint doses in different areas depending on what you're trying to treat. And if you're trying to treat gross tumor, you want one dose of radiation. If you're trying to treat the lymph nodes that might have microscopic disease, you want another dose of radiation. Can you do all that simultaneously? And the software and the hardware that we've developed over the last 10 years and 15 years is allowed to do it. And now even when the patient's on the machine, we have image-guided capabilities here and motion control and 4D motion assessment to track the patient's motion while we're actually treating the patient. And the fact that we can look and see the actual tumor each day when we're treating it right before each treatment with real-time motion changing and tracking with the patient is really exciting and allows us to have even more precise delivery of the radiation. So what's the real take-home message in head and neck cancer? What have we learned over the last 25 years? I tried to go ahead and just summarize it in one slide. What we learned with a meta-analysis, and a new meta-analysis is coming out about this, is that concurrent chemoradiation is still the standard of care. You can give chemotherapy prior to the radiation, you can give chemotherapy after the radiation, you can give radiation alone, all a variety of different ways to do it. But when the push came to shove over and over again on thousands and thousands and thousands of patients, it still came out that concurrent chemoradiation, typically a cisplatin-based approach, other people use taxanes, was still the best in terms of giving an absolute benefit at 5 years. Now, this looks, at face value, if you're not a physician, you think 6.5%, that's it? That's not a lot. And you're probably right. But in our world, that's considered some achievement. Now, the thing is, if you take out the base of the tongue and the tonsil, the oral pharynx, and you look at the data again, it really gets to be crappy. Okay, now you're under 4% basically in benefit. So if that's the best we've done in the last 25 years, we really have some problems. We have some real unmet needs. And so the take-home message is currently the standard of care is high-dose cisplatin and radiation, which is not non-toxic. We have a lot of unmet needs in radiation oncology, whether it's inadequate local control here and a variety of different tumors here. Certainly this has been in the forefront recently with various people in the news getting glioblastomas, and no matter how much radiation we seem to give, we're just not really doing the trick. Metastatic disease, we're starting to look at outcomes here and how radiation may actually impact these areas here. Jim Welsh may say a little bit about this and going after what we call oligometastatic radiation, where we're going after metastatic deposits with high bursts of radiation while they're getting various types of new drugs like immunotherapy. It's very exciting. We're starting to, as I mentioned here, starting to say, can we treat almost any tumor, including head and neck, in a week and a half? If we told you we could treat you in a week and a half and then perhaps give you some new novel drugs like immunotherapy drugs, wouldn't that be attractive to you and do it safely versus you having to come to our clinic 5 days a week for 7 weeks? So better local control improves survival and quality of life. Time and time and time again, if you don't get local control, you're not going to live. Okay, time and time again over the last 20 years, when you show that you got local control, it typically leads to an improved survival. And that's really important to be able to say that. And that's certainly true in head and neck cancer. There's no doubt about that. And so whether it's destroying tumors before local invasion, whether it's preventing tumor metastasis by treating it at an earlier stage, whether it's adding chemotherapy to try to treat both occult metastatic disease, but also in the local disease to help the radiation work better, all these things are really, really important. Radiation and breast cancer, we showed, again, that post-mastectomy radiation significantly improves survival. So we know that our radiation is important and it counts, but it still gets down to what's the risk-benefit ratio for these patients. So what are our goals as radiation oncologists? We want to treat the primary tumor and the tumor site and lymphatics that are at risk. We want to spare as many normal structures as possible to minimize side effects. Can we go faster? Can we be tighter? Can we be cost-effective? And can we cure with an excellent quality of life? I tell our residents, we're not radiation oncologists. We're oncologists with radiation expertise. And we look at this holistically. And we say to ourselves, okay, this is what we can do with radiation. We're continuing to improve our technology, but there's so much more out there. There's so many other things that we can do. And can radiation start to maybe become the fire starter, not the fire, and start to look at making other drugs work better? Or can we use very focused type drugs that are going to interject and help the radiation work a lot better without increasing the toxicity? And that's the critical part of this. So where's the landscape taking us? Well, we need innovation. We're seeing a lot of exciting things happen with computational advances and artificial intelligence in terms of our planning and predicting outcomes in terms of how patients are going to respond, and even using it to perhaps predict who's going to respond to novel agents or immunotherapy. We're looking at even more advanced image-guided radiation tracking systems while the patient's being treated. You're going to hear a little bit from Jim Welsh about particle therapies and how that might enhance some of the nanotechnology that we're all interested in the room for. I'm very interested in looking at combination therapies with targeted drugs like DNA repair inhibitors, and especially radiation therapy as a primer for immunotherapy. So we have to do better. Head and neck's a wonderful opportunity to do better because we've been stagnant for the last 20 years, 25 years, especially with the P16 negative patients, the patients who are the smoker and drinkers. The P16 positive or human papillomavirus head and neck cancers, that's kind of a different group, but it's a very interesting group too because we're seeing these guys, these 40, 50-year-olds coming in who are very healthy with these P16 positive HPV cancers. And we're thinking, good gracious, we're going to give them 70 gray of radiation and they're going to have to live with that for the next 20, 25 years. Is there something we can do better? Can we use new technology, perhaps nanotechnology, to interject and to reduce the radiation dose in those patients and still get the same cure rates and reduce toxicity? So all these things are really important here because we've remained stagnant over the last 25 years. So this is an area I'm extremely interested in. I know Dr. Welsh is, Tanguy is, everybody in this room in oncology is interested in this. It's a hot topic. And where can we amplify? Because even though everybody's very excited about immunotherapy, if you really look carefully at the data, we're still only helping 20% of patients. Can we as radiation oncologists do something different to amplify and really change this scenario here? So 85% of patients are responding, not 20%. So this is an area, but there's so many different ways to look at this, and radiotherapy is one of those combinations. So I look at it as, we used to think ourselves as the fire. Can we be the fire starter now? And can something help us be a better fire starter? And hopefully that's the nanotechnology that you're hearing about. So radiation induces multiple immunology changes or immunomodulatory changes that may influence response. You'll hear more of that from my colleagues today here, so I'm not going to spend too much time. But radiation changes the landscape. Prior to radiation here, you have your tumor cells, you have your dendritic cells. Once you hit the tumor with radiation, it pisses the tumor off. But it does some good things and bad things. But one of the good things it does is it can amplify the expression of certain immune mechanisms that may then make the tumor much more responsive to immune-enabling drugs. And that's something that's very exciting, something that we're learning here over the last 5 years, that we really could be one of these incredible modalities that changes the whole microenvironment landscape. So we improve response to these immunomodulating agents. But we can only give so much radiation. So can we do it in a different way that allows us to amplify and dramatically amplify and taking most cold tumors or many cold tumors and making them hot tumors? So they're now going to respond to new drugs. So I guess I look at it this way in terms of outstanding clinical questions here. From a sequencing standpoint, how do we do this better? From a dose and fractionation standpoint, can we utilize hypofractionation or accelerated radiation where you're giving just 1 week of radiation instead of 7 weeks? How do we do that carefully here? How should we start to look at immune modulating agents, targeted drugs, nanotechnology in terms of how it should be administered in relationship to radiation? And do we even need to start treating the lymph nodes? Do we need to continue to treat the uninvolved sites anymore? We traditionally do that in head and neck cancer. Do we really have to do that? If we become the fire starter, not the fire, maybe let the new drugs take over. Let us make the drugs work and do their job. Let us make the immune system do its job instead of us treating such big fields in head and neck cancer and adding in so much more toxicity. Can we really change the paradigms of what we're doing and push the envelope a little bit? So in conclusion, I've mentioned some of the unmet needs in specific areas here, and that also includes toxicity and reducing it. High quality radiation is absolutely critical to this. Radiation oncologists, we need to be engaged, and we need to ask novel radiation questions here, and that's so critical for advancing our field. And there's opportunities here, I think, with some of these new drugs and new agents, especially the nanotechnology, to really, really improve what we're doing. So I think I'll end there, and I appreciate your time.